in the thyroid hormone synthesis from the first to the last part. Okay, I just want to put the order of how we synthesize thyroid hormone. Now, minus looking at this, can someone just describe for us, like, how the thyroid hormone is synthesized, starting from the instructions coming from the hypothalamus, pituitary gland, and then to the thyroid gland? Mhm. Thank you so much, Doc, for the nice description. So, already said, the hypothalamus releases releasing hormones. So, this guy will release the thyroid releasing hormone. Pituitary gland releases stimulating hormones. So, it's going to release the thyroid stimulating hormone. That will stimulate now the thyroid gland to release the thyroid hormone, which is T4 and T3. Now we know that majority of the thyroid gland is actually T4, but the potent one is T3. Okay, and we need to take note that when we produce the final product, the T3 and the T4, these two guys, they are now going to send a negative feedback loop. They will be inhibiting the pituitary gland from releasing TSH. That is the long feedback loop. They can as well inhibit the release of the thyroid hormone by the short inhibitory loop at that point. So that's what the down part of the question is saying. Thyroid hormone release from the thyroid gland inhibits release of thyrotropin releasing hormone and thyroid stimulating hormone. So it can actually inhibit also the hypothalamus. So the hypothalamus, the pituitary gland can be inhibited. Drag the or click to match the correct word. Thyrotropin release. So we've already talked about this, isn't it? Thyrotropin releasing hormone is coming from the hypothalamus. Thyroid stimulating from the anteropituitary. Thyroid hormone synthesis in the thyroid gland. The doc already said is via G coupled receptor. And then when the thyroid hormone released inhibit inhibits release of thyrotropin releasing hormone, that's a negative feedback. So let's before we can answer these questions, also just to make sure that things make sense, would someone describe a bit of how the thyroid hormone is made? Some brief steps of how the thyroid hormone is made, so that we can make sense of those options which are down. Anyone? Just a quick description. Thank you so much, Doc. Yeah, so basically what the doc has said, let me just write that here so that it just can add up. So the first thing when we are making the thyroid hormone, actually, we are going to make thyroglobulin. So I'm going to use this line to represent thyroglobulin, and this is basically a glycoprotein which is made in the rough ER, and it has got amino acid tyrosine. So I can just put a T somewhere there, also maybe somewhere there. So that's thyroglobulin, which has got tyrosine. Okay. And then what is going to happen later on, we are now going to have the iodide being pumped, because this is happening in the, we have got these cells, the thyroid gland, we are going to have the choroid. So that's where we're going to find the thyroglobulin. Then now we're going to be pumping iodide. Okay. So iodine, iodine, this is uncharged. This is the one that is found in the food, like for example, salt and seafoods. So what we need is actually the iodide. That is a raw material, the charged one. That's the one that is going to be pumped into the cell. And the pumping actually is stimulated by thyroid stimulating hormone. And then what happens that when we get to pump that iodine into the cell, then now it will start combining with the thyro with the tyrosine that is present on the thyroglobulin. But before then, if you took iodine, the one which is uncharged, you are first supposed to, it is going to undergo some oxidation. Actually, when you took the iodide, the one that has got a negative charge, so there's going to be iodination, but away from that because that's more of the physiology. So we are interested in iodination, which is also known as organification, where we are now going to start adding iodine to the tyrosine. Remember, normally the food that we eat, like the salt, contains the one which is charged. We have converted it to the one that is uncharged, that is in oxidation. And then the uncharged guy now will start adding it to the tyrosine. So we are going to see this tyrosine, the which is present on the thyroglobin, we are going to add the I there. And then also to this other tyrosine, we can add another I. And of course, there's an enzyme there. So when one iodine is attached to the tyrosine residue, we are going to form the MIT. You can see one iodine to one tyrosine, that's forming MIT, mono iodotyrosine. But when two iodines, so we're going to see one I here, another I here, that binds to the tyrosine. Then we are now forming DIT. What is happening to my board? So I've got the DIT. After that, what will be happening will be now the coupling, because we have got a lot of this. So if we couple the DIT with the MIT, mono and di, we are going to form now the T3. If we get two of the DITs, we couple them together, di plus di, that will form tetra, so that will be T4. So that's how we'll be making this hormone. Hope that's okay. Just what the doc described. So in the process of organification, this is basically the process of making iodine, or we can call it physiologically iodination, where we're adding iodine to the tyrosine. That's organification. Tyrosine residues on the thyroid plus one iodine. We know that's MIT, right? Tyrosine plus one iodine. Tyrosine plus two, that's DIT, diiodotyrosine. In the process of coupling, that's when we combine those. DIT plus DIT, we know that is T4 thyroxine. And then MIT plus DIT, that's T3. Regarding thyroid hormone in the thyroid follicles, five times more. Like T4 is majority. You have got more T4 than T3, because mostly the T3 is not free, it's bound. In the peripheral tissue, 80% of 4 triiodothyronine in the peripheral tissue in form is from T4. Okay, so this thing here, majority of the T3 that we have will actually be coming from T4 because the majority of the thyroid hormone is in the form of T4. So we'll be converting the T4 into T3 in the tissue because that's the majority. I think that's basically about this part. I don't know how we can answer how we can do this one. In plasma, triiodothyronine is less, and we know this, right? T3 is less in plasma and is less bound to albumin. Prealbumin and thyroxine binding globulin than T4 and hey, okay. Half-life of, and this topic is Dr. Chidimayo who taught, so meaning that we really need to at least make sure we attempt properly the questions. Half-life of dash is short. Let me ask like this. The half-life of T4 and T3, which one has got a longer half-life? T4 has got a longer half-life. Thank you so much. That's why we can actually even end up converting it to T3. So half-life of T3 is short. Half-life of T4 is long. Metabolism of thyroid hormone occurs in the liver by gluconidation, where you are removing the iodide. It's also known as deio- deiodination. We are going to be removing the iodine from the thyroid hormone, and that's how we are deactivating it. So we are removing iodine. Please take notice, iodine, the uncharged guy, not the iodide. That's found in the food. So when you remove it from T4, when you remove iodine from T4 in deiodination, you form T3. And for both of them, as you remove the iodines, you'll be inactivating them. And then what remains now can be excreted into the bile. Approximately 60% of T4 is reabsorbed via enterohepatic circulation, and it is reabsorbed as T3, you can see, triiodothyronine. Bile acid sequestrants such as cholestyramine can reduce plasma thyroid hormone levels. This one we did talk about it. Would someone describe a bit again of how the bile acid sequestrants work, the mechanism of action? Anyone that can describe? Thank you so much. There's nothing really to say on that. It's crystal clear. So that's what the other was describing. Risk factor for type 2 diabetes mellitus, obesity. Any any other risk factors for type 2 diabetes mellitus? We know basically things that are causing obesity. Like yes, thank you so much. Lack of exercise because it can cause someone to be obese. Anything else? We are revising pathology also here. Also a bad diet, right? A diet that is too much rich in fatty food. Okay. Insulin formulation that is not used as an IV but subcut. protamine. I want to ask on this one, what class of drug is protamine? Anyone that knows the class of drug protamine is? Okay, since it's a revision, mm, yes, please you can. Okay, thank you so much. An intermediate acting insulin. What what is the gold? I want to say gold standard. The first line drug in the treatment of diabetes, specifically diabetes type 2. Let me say that. So, metformin. Thank you so much. And then we can make it. What is a major side effect for metformin? That would make us okay. In case there's another option, we end up going for another option. Metabolic acidosis. Thank you so much. And then, so we know metformin is a big one. What is the mechanism of action? Thank you so much. And another question I want to ask about metformin is how does metformin how can metformin end up causing megaloblastic anemia? Anyone that can help with that? So it actually it reduces the absorption of vitamin B12 and folate, so we expect it to be able to cause reduction. And then which class of antidiabetics is not related to hypoglycemia and weight gain? Metformin, it doesn't it show weight gain and hypoglycemia? The glucose transporters, yes, those are the only ones. Sodium glucose transporters. And then the next one, which class of name the class of antidiabetics that work by binding to the sulfonylurea receptor 1. It's even in the name, the sulfonylureases. Of course, there is another one that binds to the same. They are known as meglitinides. They also bind to the same receptor. And then, which class of antidiabetics bind to the DPP4 receptor? Incretins. And then those which bind to PPAR gamma, TZDs. Thank you so much. I think that's a good revision there. Okay. And then we can oral antidiabetic drug class that increases secretion of insulin. Biguanides. It's a biguanide that also includes metformin. Now, let me ask again, because when you look at the way they've described the mechanism of action, there are some drugs and diabetic drugs which reduces the risk, which decreases sugar levels, but it does not stimulate insulin release. Which ones are those? If someone has read, they are going to reduce blood glucose, but they don't stimulate the release of insulin. The Bergona is the same example of metformin, oral antidiabetic drug that increases secretion. So I'm now looking at this one. Why the answer is biguanide? If it biguanides don't stimulate the release of insulin, because this is from a link. Anyone that maybe has got an idea why it is biguanides here? Okay, thank you. So it is glyburide sulfonylureas. The same etiology causes the same etiology as systemic lupus erythematosus. Okay, we know SLE is an autoimmune infection. The only class and diabetic drug indicated for management of type 1, that's insulin, right? Route of soluble insulin used to treat diabetic ketoacidosis. Intravenous route of soluble insulin used to treat diabetic keto. To treat DKA, you use the IV route. That one, there's no way we can forget. That's the same with that. Which injectable drug treats type 1 and type 2 diabetic mellitus? Is there anything else besides insulin that can treat both? It's only insulin, thank you. Lifestyle management for diabetes mellitus includes dash low fat, high fiber diet, dash low fat, high fiber diet. So the doc already explained you need exercise because of course you are burning some calories, low fat and also high fiber diet to be able to those are some lifestyle modifications. Insulin release depends on the cation influx into the pancreatic beta cells. Calcium. I want to ask on this one on the mechanism. Any drug that we know or class of drugs that works by this mechanism, when they bind to their receptors, they are going to stimulate the entry of calcium into the cell. Actually, potassium will be leaving the cell and then calcium will be entering. And that's how they end up to the leading to the exocytosis of calcium. Any class, the sulfonylureases. Is there anything else? The meglitinides, yes, thank you. Subcutaneous dash insulin is absorbed more slowly because of crystal size. Lent insulin. Again, this one I think I saw in MCQs. What class of insulin is this? Is it the long acting, short acting, or intermediate? The lent insulin, intermediate, and it is absorbed. It is crystal in nature, so it is absorbed more slowly. And then the ultra lent is which class? Long acting. Right. Symptoms of okay, so I'll be doing this so that we'll not be seeing the symptom of type 1 diabetes mellitus includes polydipsia, dash, and I don't know the last word. Okay, let's just talk about the symptoms of diabetes. I think there is it 5 P's or 4 P's, the major P's in diabetes symptoms. Anyone that can help with that? Thank you so much. Polyuria, polydipsia, polyphasia, and there is actually a relationship as to why this is even happening like this. Because when you look at polyuria, someone is urinating very much. So, in order to substitute the more urination that is happening, they'll start taking more water. But there is still another P which I'm remembering, unless otherwise on the symptoms. Okay. So there's also, so it's not even a P. Polydipsia, polyuria, polyphasia, and also glycosuria. So if someone is urinating urine in, and that is going to lead to loss of weight and such things. Okay, so polyuria there. Drug that stimulates pancreatic insulin secretion are called insulin dash. What is the name of the drugs that promote the secretion of insulin? Insulin what? Secretagogues. Thank you. Oral antidiabetic medication for treating type 2 diabetes mellitus increases insulin uptake into tissues. Which one is that? It's oral type 2 diabetes. It will increase insulin uptake by tissues. Pardon? Metformin. Remember, it doesn't cause the secretion of insulin, but just it will increase the way the tissues are using insulin, though it's not stimulating this secretion itself. Pancreatic beta cells are the ones we know which produce insulin. The trade name for glipeclenide. What class of drug is glipeclenide? A sulfonyl. Thank you so much. So that's downhill. Glipeclenide downhill. The organ that produces insulin are that one we know already. Lifestyle change recommended for type 2 diabetes mellitus is weight loss. Okay. So I want to arrange the following insulin information from the most rapid onset of action to the longest onset. So that one you can just look at them. I've got the Lisipro, NPH, which is lent, and then protamine, zinc, ultralent. So the ultralent is the doc said this what? It's a long acting, isn't it? It's actually a slow, supposed to be, it is a slow acting, the ultralent and protamine. And then those which are rapid acting, you have got the regular insulin. There's also Lispro and Aspart. And then the intermediate as well, I've got NPH and Lent. The slow is the ultralent and protamine zinc. So we have got two there. So for the slow, you can remember them by using SUP. Slow for the S, and then U is the ultralent, and then P is for the protamine. For the intermediate, don't forget that there is a lent and the NPH. And then what remains then is going to be the rapid acting. So this is arrangement from the most rapid. So the most rapid is the least pro, yes, aspart, and the regular. NPH lent and glargine, you can see that's intermediate. And then the slow acting protamine zinc and the ultra lent. That's this SAP. Arrange from the most likely to cause hypoglycemia to the least likely when used as monotherapy. The drugs that increase insulin secretion also cause weight gain and eventual insulin resistance. So the insulins are the first ones when it comes to causing hypoglycemia, and then sulfonylureas, and then meglitinide, and then these guys shall bind into DPP peptidase for inhibitors, and then TZDs and those others. So meaning that majority of these guys, can see majority of them, they are at the bottom here. Majority of them are better. The worst when it comes to causing hypoglycemia is insulin itself, and then followed by sulfonylureas and the meglitinides. So we can just remember that the two that work by the same mechanism of action are very much good when it comes to causing hypoglycemia. And then the DPP4 inhibitors. DPP4 inhibitors, what are they called? These drugs that inhibit DPP4, you see, I've even seen the name is there. The incretins, thank you so much. So drug, the correct word, sodium glucose transport protein 2 inhibitors. So I want to give an example. So there is the remogliflozin, and then glucosidase inhibitor. Yeah, for this one, there's only one, and we have to know it. It's only acarbose. You can just think of alpha and A, acarbose, alpha glucosidase inhibitor. How do alpha glucosidase inhibitors work? Anyone that can help that? Thank you so much. Glucose can only be absorbed as a monosaccharide. Actually, glucose is a monosaccharide, so carbohydrates can only be absorbed as monosaccharides. You are preventing the enzymes that can break them down, so that means that there is no absorption. And for this, we should take note. Imagine someone took milk. Milk, is a disaccharide, right? You have got a lactose. So meaning that if you have inhibited this enzyme, you can't absorb that. And you know what milk does, right? If it's going to cause osmotic diarrhea. So water will start moving. That causes flatulence, bloating, abdominal discomfort. That's why this drug, the alpha glucosidase inhibitors, they have got those side effects: diarrhea, abdominal discomfort, bloating, flatulence. And then DPP inhibitors, DPP4 inhibitors. So these are basically incretins. Any example of an incretin? Sitagliptin. We have got natural incretins like the glucose, like prot, po- that's GIP. Is it polypeptide? Hope it's polypeptide, yes. GIP, GLP, those are natural ones that will reduce glucose. Sitagliptin is also an inhibitor of it's an incretin. And then insulins, we have got the regular, which is NP4. Big guanides, we know the common, the prototype metformin. Sulfonyl, sulfonylureas, glyburide, and then incretin mimetics, exenatide. And then for meglitinides, these guys end in paglutinide. So if you just see a way that ends in glutinide, you know it's a meglitinide. And they've got the same mechanism of action like the sulfonylureases. The TZDs, all of them end in glitazone. Glitazone, just like that. So now these are some. Multiple choice answers. Sulfonylureas include gluburide and glibenclamide, which is down here. Which of the following statement is true about this drug? Reduce the blood sugar by reducing glucagon secretion from alpha cells. They never cause hypoglycemia because they are not insulin secretagogues. Reduce the blood sugar by increasing insulin secretion from beta cells. Sodium glucose transport protein 2 inhibitor have comparable glycemic effect. Yeah, can someone just comment on the answers? We already know the answers, but just a comment as to why you support why the answer is really correct. Reduce blood sugar by reducing glucagon secretion. Of course, we know this is one mechanism, right? Besides them stimulating the secretion of insulin, they're also stimulating, inhibiting actually the release of glucagon because glucagon is going to increase insulin. Most of the antidiabetics will also do the same. C. Reduce blood sugar by increasing insulin. We've just said that. Sodium glucose transporter have comparable glycemic effect. So meaning with these sulfonyl ureas and the sodium glucose transport inhibitors, they have got nearly the same effect when it comes to the reduction in diabetes or managing the condition. But then let me ask, between the two, which one do you think? Uh, okay, how do I put this question? Which one is much better when it comes to the profile in terms of causing hypoglycemia and weight gain? Between the sulfonylureas and the sodium glucose transport protein 2 inhibitors. So the sodium guys are better because they don't cause. Please don't forget they are the only ones which don't. Which of the following statements is true about management of diabetic ketoacidosis? Patients on oral antidiabetic drugs, including metformin, must be switched to soluble insulins. Upon stabilization and control of precipitation factors, patients on metformin before the diabetic ketoacidosis episode can continue metformin if there are no contraindications. Long-acting subacute insulin can still be used in patients with severe dehydration and cold clammy peripheries after stabilization and controlling precipitation factors. The 24-hour insulin requirement is converted into equivalent short-acting and long-acting insulin formulation for steady blood sugar control. Uh, First, before we even look at these options, I want to ask on the complications of diabetes type 1 and type 2. What are the complications for each? Like the major one, diabetic ketoacidosis, thank you so much. And then type 2, honk, thank you so much. So for option A, we want the true ones. Patient on oral antidiabetics like metformin must be switched to soluble insulin. Is Does anyone have any thought why it's so? Why? Yes. Okay. So meaning insulin is much faster looking at the mechanism of action by which, I mean, the mode of delivery in which we are giving. Insulin is given by which delivery? Is it IV, IM, by what method? Thank you so much. So IV because it's going to be much quicker because of the condition. And then thank you. And then two, upon stabilization and control of precipitation factors, the patient on metformin before the DK can continue if there are no contraindications. The doctor just explained this one. You can now continue to give them after they've at least gotten better. And then C, long acting subcut insulin can still be used in patients with severe dehydration and cold. Why is this answer wrong in case someone read on it? Long acting subcutaneous insulin can still be used in patients with severe dehydration. Why is it not correct? Anyone with a thought? One thing about these insulin formulations is that they can cause sodium retention, and when someone is retaining sodium, you expect them to have edema, but really don't know how is contraindicated in this condition. Maybe it's one of those we are going to swat. A long acting subcut insulin can still be used in patients with severe dehydration. Don't do that. After stabilization and controlling precipitating factors, the 24-hour insulin requirement is converted into equivalent short-acting and long-acting insulin formulation for steady blood sugar. That's true. One of the significant side effects of sulfonylureas, such as glibenclamide, is hypoglycemia. Which of the following statements is true about this side effect? Hypoglycemia caused by glibenclamide may last longer than hypoglycemia caused by short-acting insulins. Oh, so we have learned one fact there. We can see it can last longer. It can be treated with one bolus dextrose infusion because these drugs have short half-life. That's not true. The patient would need close monitoring and severe dextrose infusion because the drug have a long biological half-life and the blood sugar will drop after the first infusion. Yeah, we know that sulfonylureases have got a longer biological half-life than the elimination half-life. What does that mean? What does it mean if they say longer biological half-life in comparison to elimination half-life, which is shorter? Anyone to help with that? What does it mean? Longer biological half-life, short elimination half-life. Any comment? And this is one fact that we need to know about sulfonylureases or ureas. When you give the drug is going to be excreted, but even after excretion, it will still be working. Thus, the biological half life is longer than the elimination half life. It is not advisable to continue to combine insulin and glibenclamide because the risk of hypoglycemia would be too high. Metformin would be better choice to use with insulin if blood sugar control is not achieved on oral antidiabetic monotherapy. And yeah, we need to take note of this, like these drugs that cause. Anyway, let me allow if someone wants to comment why this statement is true for something that they might have read. Why is not advisable combining antidiabetics? Any comment? I just love someone to say something because that one word that you are going to say will be a reason why someone can't forget it. So it's more like a synergism of side effects. When you give these guys, which are they are all causing hypoglycemia, when you give them together, they're actually going to worsen that. So you don't advise giving them en masse. Don't give them together. TZDs increase insulin sensitivity and do not cause hypoglycemia or weight gain. Yet they are less commonly used in diabetes mellitus type 2. Which of the following reasons accounts for this? The side effect profile of TZDs is poorer than that of drugs such as metformin, which promote glucose uptake in peripheral tissue without causing hypoglycemia. TZDs increase insulin sensitivity and do not cause hypoglycemia, so they have the potential to replace insulin in the management of type 1. The PPAR gamma is found in many tissue, reducing drug selectivity. TZDs are more efficacious and safer than other oral antibiotics. However, the cost makes them less useful. What are some of the side effects for the TZDs? Anyone that can help with that? We know the mechanism of action, they're inhibiting the PPAR gamma. But any side effects that we know for the TZDs? All right, thank you so much. They have got problems also on the heart. So you actually don't use these drugs in heart failure. They are contraindicated. And we've said they are as well able to cause edema. Yes. And they can cause fractures, and you don't use them in pregnancy. They have got two main side effects, and that obviously will be because of C. The the this receptor is found in many tissues, and so there's reduced selectivity. And the side effect profile is poor, as we have said, because of being found in a lot of tissue. Actually, that is one fact about every drug that is binding on a lot of receptors. For example, the tricyclic antidepressants are bad because they have got a lot of receptors where they can work. The first generation antipsychotics. And B, TZDs increase insulin sensitivity and do not cause hypoglycemia. So they have the potential to replace insulin in the management of type 1. So why is this statement false? Anyone that can comment on it? TZDs increase insulin sensitivity and do not cause hypoglycemia, so they have got the potential to replace insulin. So even though, like when you look at the way these guys work, because in insulin type 1, the problem is these guys will be promoting, will be actually causing the production of insulin, right? And in type 1 diabetes, we don't have any pancreas to produce that has got capacity to produce insulin. So there's no way they can replace insulin in type 1 diabetes. TZDs are more efficacious than others, of course, that's a joke. First generation sulfonylureas are less used than second generation. Which of the following statements may explain the reasons for the greater popularity of second? Okay, let someone just comment on that before you can even look at the options they've given. You can even give it generally. Why is it that the fifth generation cephalosporins are better than the first generation? Second generation and uh, these ones and psychotics are better than the first. Why is it that the second? You can even just give a general description. The second generations or later generations are always better than the first. Or you can even be specific for this question. Anyone that can help with that? Thank you so much. That's one important one. They have got fewer side effects. And that's probably because when we are developing more drugs later on, we are trying by all means to ensure selectivity. So, meaning the drugs are more selective and so they reduce on the side effects. So flushing and hematological toxicity may occur with some first generation of drugs. So that's why you'd rather go for second. Second generation have a short duration but predictable half-life and longer duration of effect. You can see this statement. This is the one we are saying biological half-life. Second Gs have a short but predictable half-life and longer duration of effect. They will still remain working even when they've been excreted. First generation causes hypoglycemia and weight gain, unlike the second generation. So this statement is not true. I will still ask why. Is anyone that can comment on why this statement is not correct? The first generation caused hypoglycemia and weight gain, unlike the second generation. Anyone that wants to comment, why do you think this statement is not true? Actually, whether it's first generation or second generation, they will still cause the hypoglycemia and weight gain. The improved aspect that we are talking about as to why second generation guys are better is because of the flashing and the hematological problems, and also the second generation having a longer biological half-life. First generation drugs have a varied half-life and unpredictable time to peak effect. This is a disadvantage. Remember also when you're talking about drugs that are used as is it agonists for the thyroid hormone? There are some drugs that are collected directly from animals, like the animal thyroid gland is just gotten and then it is dried. If you remember on the thyroid gland, and those drugs have got DMT, they've got MIT, they've got T4, they've got T3. And we said it's actually a disadvantage because we don't know how much percentage of the active component is in the drug. So you can't really predict when the drug is going to be effective, when it is working, and how long it's going to take working like that. So that's a disadvantage. When there's too much, I would say too much good things, right? Like everything is there DMT, MIT, and T4, T3. Imagine everything all together. So that's why we preferred using those drugs that had more of the T4 to T3 ratio. Which of the following are examples of incretin hormones that lower blood sugar? We already mentioned these. We said that incretins, we have got those natural ones, GIP, GLP, sorry. We talked about those already. For the sake, follicle stimulating hormone. What are the effects of this hormone? Remember, we are revising all the courses now. You can even touch the pathology if you want. What are the effects of the follicle stimulating hormone? Anyone that can say just anything? Be free be free to comment any thought. Okay. So this was actually supposed to be follicle stimulating hormone at follicular FSH. You know the follicle stimulating hormone is going to stimulate the ovaries, yes, to start now. Those stages, like from the primordial follicle to the primary follicle to the to the Graafian follicle, to start happening. You also have luteinizing hormone now when the ovum has developed now to extrude it, to remove it on the 14th day. That's luteinizing hormone. And then adrenocorticotropin hormone is going to stimulate the adrenal gland to cause the production of cortisol. What are the effects of cortisol on the body? Anyone that can help? Any effect that you know of cortisol on the body? Or we don't want to revise, that's not pharmacology. Okay. Which of the following statements is true about the role of incretins in maintaining blood sugar? Regulate pancreatic cell function. That's true. Incretins want to reduce glucose and they can use the pancreas. Increase insulin secretion. That's true. Reduce glucagon. That's true because glucagon is opposite to insulin. Cause satiety after a meal and reduces appetite. What is satiety, anyone? Fullness. So it will cause someone to feel full so that they stop eating. When you stop eating, maybe you are eating in 15 laps of, okay, you are eating zigolo with buns, and you know that there's sugar there. So you, if you feel full, you stop taking the sugar, and at least that is going to help. And then this is one important as slow gastric emptying time. Incretins, when they are released, they will stop the stomach from releasing the contents which are there. Because when the stomach releases its contents, the content will go into the duodenum, and that's where absorption is happening. So if you stop the gastric emptying, it means that there's nothing that the duodenum will be able to absorb. So if it's a sugar, no absorption, and so that will also help in maintaining normal sugar levels. TZDs, rosiglitazone, lower blood glucose levels via which mechanism? Okay, before we even look at that, what is the mechanism of action for the TZDs? Any comment? Yeah, thank you so much. That is true. Number one, they are going to increase. Just think of all good things that will reduce sugar. Number one, as the doctor said, increasing tissue sensitivity to insulin. Number two, anything else? We, thank you so much. That's also very important. You know, gluconeogenesis is making glucose. So it will also stop the production of glucose because that's what we're trying to fight. And then number three, anything else? Inhibiting lipolysis, because when you break down lipids, you are going to end up using them to produce carbohydrates in beta oxidation. So you also stop that. Thank you. Anything else? How about on glucagon? What do we think is going to be the effect on glucagon? Yes, also inhibiting the release of glucagon. Okay. So increase glucose uptake by the cells. You know, when glucose is in the blood, that is what is known as hyperglycemia, diabetes. So you now remove that glucose from blood, you take it into the cells. So that's one effect, and then you would have reduced the glucose in the blood. Decrease insulin resistance, right? If you decrease insulin resistance, you are increasing the sensitivity. So that's the same thing. Reduce liver gluconeogenesis, increase adiponectin, which increases glucose uptake into muscles, so that someone's now at least gain some weight. Which antidiabetic drug do not cause hypoglycemia? Anyone to comment on that? Which ones don't cause hypoglycemia or weight gain? Yes, and from the question that we saw on top, actually, even the TZD is actually doing that. So sodium glucose transporters, you would wonder why biguanides are also there. Or maybe there's something that I haven't read. Anyone that has read, why is the biguanide also included? or not causing hypoglycemia or weight gain? They do cause, isn't it? They don't cause. Also, it's only on weight gain and not hypoglycemia. Okay, thank you so much. I'm just trying to double check that. So in their notes, yeah, it's rare. So it's just that it's a low risk, huh? And how about weight gain? Has something been mentioned about weight gain with the big one? I think that's why it's not correct on the weight gain part. So it can cause some hypoglycemia but not weight gain, all right? And then, okay, so that's that. And go to the next. Which of the following is true of type 1 diabetes mellitus? Okay, before we even come to here, can someone just say anything that they know about type 1 diabetes mellitus? We can talk about cause and treatment, just anything. The only treatment is insulin. Thank you so much. Anything else that is special to diabetes type 1? Thank you so much. Autoimmune disease. We can also talk, just to be fancy as pathologists. Someone can mention a bit of ecamapathology, which is going to differentiate it from type 2 or ecama complication. Thank you so much. Complication DKA. Right. So which of the following of type 1 diabetes mellitus patient produce inadequate amount of insulin? We know that's true. There is muscle and adipose tissue. Their muscle and adipose tissue are sensitive to insulin. Yes, remember the problem is not insensitivity but lack of production of insulin. So if you just give insulin, that's why it is going to use to treat. Weight gain is significant risk factor. Weight loss is part of therapeutic management. Why is this option not true? It's type 2 because type 1 is normally genetic, right? And then they can only be effectively managed by insulin replacement therapy, and the doc just said that. Which of the following is true of type 2 diabetes? And now we go to type 2. The same things that we mentioned about type 1. Anyone to comment on that? Starting from the cause, treatment, and complication. Thank you so much for that. I think we've gotten that on the cause and treatment. We know that any other anti-diabetic drug that we know is going to be used for treatment, right? Complication, the doc already said honk. So which of the following is true of type 2 diabetic patients? Produce adequate or increased amount of insulin. How is that option? Or maybe I've not gotten it properly. Produce, okay, it's true, isn't it? Ye- Thank you so much. Insulin is fine, but the cells that are supposed to use the insulin are the ones not fine. Produce increased amount of glucagon. So in this condition, someone has got glucose, and the body is still telling the body, because you have got glucose but it's not in the cells. Because the glucose is in blood and not in the cells, the body is still recording that you don't have glucose. So because of that, it is still sending instructions to the pancreas to say produce more glucagon so that it can stimulate the uptake of glucose. And so glucose will end up increasing and increasing and increasing like that. Produce inadequate amounts of incretins. You know, incretins are the guys that reduce glucose, so they are not enough, like the GIP and GLP. Their muscle and adipose tissues develop insulin resistance. We know that's true. Which of the following statements about antidiabetic drugs is true? Metformin doses do not have to be reduced in moderate renal dysfunction if there is no metabolic acidosis. Sodium glucose transport protein 2 inhibitors limogliflozin do not need a functional pancreas to lower blood sugar, so they are indicated in type 1 diabetes. Insulin doses does not have to be lowered in significant renal dysfunction because it is metabolized and excreted in other tissues. Hypoglycemia in the presence of alpha glucosidase inhibitors such as acarbose can only be treated by glucose, not sucrose. Last option is correct. Hypoglycemia in the presence of alpha glucosidase inhibitor can only be treated by glucose, not sucrose. All right, thank you so much. So there's another thought there. Is it glucose that we use or we use dextrose? So yeah, is dextrose, right? But specifically, I think they've made just a statement in the notes. Hypoglycemia management is with glucose and not sucrose. So the glucose that we are delivering is just that, of course, you deliver it in the form of dextrose, isn't it? Which is still glucose. Dextrose is just glucose that is in the D form. You know, we have got the D and the L. So that statement is true. Is there any other statement that is true here? Let's look at A. Metformin doses do not have to be reduced in moderate renal dysfunction if there is no metabolic acidosis. Is that true? If there is no acidosis? And another thing about this metformin is its excretion is in urine is unchanged. So meaning that the effect on the of the kidney on the excretion of this guy is not that much because it is excreted and changed. So the only contraindication is when you have got the actual metabolic acidosis. So meaning that you still maintain the dose, isn't it? Will not change anything. We agree with that. And then B, sodium glucose transport 2 inhibitors do not need a functional pancreas to lower blood sugar. So they are indicated in type 1. For this one, is there even anything to think of? As long as it's not insulin, we can't talk about type 1. And then D, hypoglycemia, or we've just answered that C. Insulin dose does not have to be lowered in significant renal dysfunction because it is metabolized and excreted in other tissues. Is that true or false? It's false. Where is the metabolism and excretion of insulin? Any? Okay. So we really need to take the statement just doesn't add up, isn't it? Which of the following about is true? Insulin dose does not have to be lowered in significant renal dysfunction. For this one, we know that insulin, uh, ok- I, direct about insulin, I don't know, but glucose is excreted in urine. But the statement just sounds wrong. I don't know why it sounds wrong, but that is not something that we can use as medical. Sounds wrong. So we need some proof. Pardon? So he said option A is not true. Liver and kidney. So meaning that the statement is not true, right? You have, because it is going to be is also the metabolism or the pharmacokinetics is also involving the kidney. We shouldn't we should change the dosing, right? When there's no proper function. So that's not true. TZDs are PPAR gamma agonists, which other group of food drugs commonly used as anti-lipid drugs are agonists at the same receptor. Bile acid sequestrant, statins, niacin, fibrates. Oh, these are anti-lipidemias, right? Yeah. So which questions are these? Okay, so